This is Dr. Amy Cranbeck from Northwestern University, and it is my pleasure to introduce Dr. Joseph John Pahira. Did I say it right?
Pahira.
Let me start that again. Dr. John Pahira, who is professor of urology in Georgetown in Washington, D.C. Dr. Pahira did his undergraduate degree at St. John's College in Philadelphia, Pennsylvania. He then completed his medical degree at Hershey Medical Center at Penn State, and he did his residency also at Penn State. He then joined the faculty at Georgetown University and established the first kidney stone disease center in Washington, D.C. He worked with my mentor, Dr. Joe Segura, and has been an innovator in the field of endourology, mainly shockwave lithotripsy and percutaneous stone removal. He's served as the president of the Washington Urologic Society as well as the Mid-Atlantic section of the AUA. And he's been the chairman of his hospital for the compliance committee, the credentialing committee, and really has helped to develop better physician communication. So I'm really excited that you'll be presenting to us today and hear about technical improvements for shockwave lithotripsy. Thank you.
Amy, thank you so very much. Let me also say thank you to Mildred, who helped coordinate this for me and got all the forms and everything filled out so we can get CME. I just wanted to say that I put this little talk together primarily for the students and the younger residents who haven't had the advantage of sort of living through some of the things that the older urologists like myself have had. And there are some things that we've learned, particularly in regards to doing shockwave lithotripsy, that I was concerned might have been lost as our use and frequency of shockwave lithotripsy seems to be going down in the last few years. Certainly in residency, it's natural for the residents to want to do the more complicated ureteroscopies and percutaneous procedures. And so my fear was that they may not be spending enough time or getting enough experience with shockwave lithotripsy. For those residents that then leave and go into private practice, where shockwave lithotripsy may be part of the routine of the practice. For those of us in academics, we know that if we ask for a flexible ureteroscope, it's going to be available. If we ask for our laser technology, it's going to be available and so forth. But, you know, flexible ureteroscopes have a limited lifespan, 10, 14 cases, and you got to send it out for repair. And so it's not always going to be available when you get out in private practice. And consequently, shockwave lithotripsy may be something, depending on where you practice, that you're called on to do. So the genesis of this talk is to sort of go back through where we started from back in the 70s and the early 80s with what technology we had, and then to walk you through some of the things we've learned over the 2 or 3 decades of doing shockwave lithotripsy to help you do it effectively and safely. So I'm just going to go ahead and share my screen if I may. I'm going to leave time at the end for questions for you so we can talk about anything else you want to cover. So if you'll do me the justice, I just wanted to go back a little bit to the past and review some of the things that we had to deal with back in the 70s and 80s in terms of managing patients. Generally, we had tried to have a fairly conservative approach. Again, I was talking about early on, we tended to realize that most stones, when they presented, were in the ureter at the time of onset of symptoms. And fortunately, most stones, 80%, were 4 millimeters or smaller. And fortunately, 80% we know will pass spontaneously with some conservative management. I think most of us back then were doing IVPs if we needed further definition of what the anatomy was dealing with. but certainly non-con CTs were starting to come into vogue in the 70s for ER management and evaluation of stones. Anatomic considerations, location would dictate how we would consider managing the stone, whether it was a large complex stone in the kidney or whether it was a ureteral stone, and the location of the ureteral stone often dictated our management decisions. Considering anatomy played a role in the type of instruments we would use at that point. We didn't have a lot of different options. Certainly, if the patients weren't able to pass their stone and they had persistent pain or bleeding, surgery was required. If there was partial or complete obstruction based on the ER imaging, we may need to take them for surgery. If there was infection associated with the stones, if on imaging the stones were too large to pass, that was an indication for surgery. If stones were found to be increasing in size over time, causing parenchymal damage, and then occasionally asymptomatic patients who had select jobs like airline pilots or State Department workers who had to go overseas, we might elect to do surgery. Back in the 70s, when I started my career at Georgetown, this is what my surgery options were. I can't tell you that I didn't have fun doing ureteral lithotomies, doing open piloplasties, doing anatrophic nephrolithotomies. They were complicated procedures. Unfortunately for the patients, they were quite painful with these types of incisions and required a drain left in for almost everybody. So there was a number of days of hospitalization and recovery time. So it wasn't an ideal time to have a stone. Composition played a role in deciding what we might do about the stone. There were some stones that we could treat medically, such as uric acid and cysteine stones. But for the majority of the others, if they met the criteria, they would need surgery. So in early 1980s, when this thing called extracorporeal shock wave lithotripsy hit the scene, it was a godsend. It was something that we all knew was going to change our lives and make things better for our patients. The original technology was created by the Dornier Aerospace Corporation. This was our original lithotripter at Georgetown in the mid-1980s, the Dornier HM3. And the Dornier company had developed this technology over a number of years, and they were doing it not so much to treat kidney stones, but the story goes that they were looking at the effects of shock waves from micrometeor showers hitting communication satellites in space. And so they were designing studies to study shock wave principles. And again, the story goes that one night at a cocktail party, the engineers were talking about what they were doing in the lab, and one of their wives was either a physician or a vet, I wasn't quite sure, who said, gee, I wonder if we could take those shock waves and focus them on, say, gallstones or kidney stones and break them up. And Dornier ran with it. And after a number of trials, I hate to think what went on during, this was the HM3, human model number 3. I don't know much about what happened with human models number 1 and 2 over there in Germany, but I suspect that they were making progress. But anyway, this came through with a lightning speed through the FDA and began to circulate around the United States gradually over time. Disadvantages with the HM3 was that it was a huge piece of bulky technology. It required at least 2 rooms for setup in order to put this large water bath in with the biaxial fluoroscopy. There was a large railroad ties in the ceiling here and this large gantry. This lift that came with it to lift the patients over into the tub was something that you would see lifting airplanes on an aircraft carrier. So it was quite an investment for a hospital to get one of these. Obviously, a financial investment as well, up to 2.5 million Deutschmarks to buy this, and then another $2,500 to $5,000 a year to maintain it. So, but it changed the way we were managing the majority of our surgical stones. And our residents at the time, we were doing as many as 25 or 30 cases each week. So they had tremendous experience with the technology. Gradually over time, over about 9 years, the technology began to come down in size and in price. We took the water bath away. We put the water and the spark gap in a cylinder that would allow us to couple to the patients with a membrane, which made things a lot more effective and easier to manipulate. Still in the early units, we were using spark gap technology, creating the shock wave, which was then focused at a second focal point. We had to get our patients positioned on the table using fluoroscopy in the second focal point in order to effectively break the stones. We went from second to third to fourth generation units. This is a Metaspec lithotripter, and again, it's a modular unit, so it was very easy to move around, to store for patients to be treated. We could even treat them with mobile units that would come into the hospital. If your hospital couldn't afford to have a $500,000 lithotripter like this, they might be able to afford having a mobile unit bring a unit in, which we couldn't do during the early phases of the HM3. Also, as we began to treat patients with this technology, we began to develop improvements in our scopes. Semi-rigid, flexible scopes all began to improve, reduce in size, effectiveness. We began to develop laser technology. Early on, we were using green energy lasers, but they didn't work that well. Gradually, we moved into the holmium laser, which, as you know, worked very effectively for us in terms of technology to break stones. Our scopes allowed us to get into all areas of the kidney that back in the late 70s and early 80s we couldn't do with the larger, more semi-rigid scopes. We could get up into the upper ureter. We could get into all parts of the kidneys. We could actually go up and very effectively begin to diagnose bleeding issues in the kidneys. We could identify papillary tumors in the kidneys, which we could treat conservatively, reducing the loss of kidneys from bleeding and upper tract tumors. Percutaneous procedures began to come into vogue in the 80s, and we developed many new techniques with that. Again, getting away from that terrible open surgery that we were burdened with early on in my career developing the Stone Center. At the end of the mid 90s, these were sort of our summary considerations for treatment options. Stones that were less than 2 centimeters could be considered for shockwave lithotripsy. If they were greater than 2 centimeters, depending on location, we would manage them with either percutaneous stone removal or ureteroscopy and laser litho. For stones of certain compositions, particularly cystine stones, we tried to avoid shockwave lithotripsy and manage those with other options, in some cases with medical management. Body habit has played a role. Morbid obesity made shockwave lithotripsy difficult in some cases. Spina bifida, complex renal anatomy like horseshoe, calyceal tics, renal arteries, and aortic aneurysms all played a role in guiding our decision making. These guys were tough no matter where you were, and it was always my recommendation that they be left to the stone centers that had the equipment and the experience, something that probably wasn't always available in private practice. So that was sort of a little walk through the past, through where we got to. And what I'd like to do is just summarize some of the things that we learned over those first 25 or 30 years of using the shockwave lithotripter, and that I'd like to share that with the residents and hopefully keep this on file for those that may not be doing as much shockwave lithotripsy and may find themselves at some point in the future needing to think about doing it and doing it correctly. Most commercial lithotripters, no matter which one you have, are fundamentally all the same. They produce
Dr.
yes.
Pahira, sorry to interrupt again. I don't think your slides are advancing. So we're stuck on one of the earlier slides.
Oh, goodness gracious. Oh. Well, I mean,
your talk is amazing, but I just, for people that are more visual, it may be, if we could, I think, can you share your screen and go to, there you go, that's it. I can see that's advanced, but it looks like it, can you put it in presenter mode? There's a button down at the right on the PowerPoint.
Most commercial lithotripters are fundamentally the same. They produce a similar waveform at F2, the second focal point, and stones are formed with micro cracks and pockets of liquids. So we're looking, we see there's a peak 1, a positive peak pressure, and then a negative peak pressure. And we want to try and take advantage of all that energy to break our stones. So we look at why stones break. Well, there's 4 basic components that we have to think about. We have the initial shock wave coming in, hitting the stone, causing compression, trying to fracture the stone. That energy wave then moves through into the core of the stone, breaking up some of those internal crystal structures with a spallation type fragmentation mechanism. As the energy wave surrounds the stone, it's creating cavitation bubbles, which can also further fragment the stone. And then this whole process creates a dynamic fatigue, hopefully breaking the stones for us into fragments that are small enough to be cleared or passed. So when we look at lithotripters, the energy source to generate the shock wave is the consideration. It's either going to be the original spark gap or now the newer electromagnetic units. The device has to have a way to focus the shock waves at the second focal point. There has to be a coupling medium, and there has to be a stone localization system. Either that's going to be fluoroscopy, or in some of the newer units now, we're going to use ultrasound. Before you start your case, and I think this is one of the more important slides, I've always wanted to consider the weakest link theory. Who's running the unit? When they come in, if you have a permanent fixed lithotripter in your OR, then generally your OR staff, in conjunction with maybe a radiology tech, are going to come in. They're going to make sure the unit is set up and ready to go. If it's a mobile unit, you may have a mobile tech coming in and setting it up. But I think as the attending physician, I'd like to be in the room, making sure that it's set up correctly, making sure that if it's a spark gap, that the spark plug was changed, making sure that the water in the unit, if it needs water for the membrane, has been changed. I want to make sure that the C-arm alignment has been done correctly so that I know that F2 is at the correct point, so that I'm going to get good fragmentation of my stone. When I have the patient positioned and I'm ready to couple them with the membrane, I want to make sure that that membrane is making complete contact, that there's not bubbles that would affect the shock waves getting through. I want to make sure that the gel that I'm using doesn't have any air in it. And so all of that takes time, and you can't just walk into the room and the technician says, here, we're ready to go, push the button. It takes a little bit of thought, and you have to understand how the technology works. Question then, how can we improve fragmentation? One of the most important things is spending more time at the second focal point. Lower rates of shockwave delivery help, and using Hounsfield's units in our pre-op evaluation to decide whether shockwave lithotripsy is the right thing at all. Spending more time at F2 will definitely improve fragmentation. It gives you better compression, taking advantage of those four components of breaking the stone. Shockwave lithotripsy units with larger F2s are more forgiving. They allow some respiratory movement. They allow the stone to remain in the second focal point for longer periods of time. And I believe that one of the successes early on of the HM3, the Dornier HM3, was probably related to the size of the second focal point. They got it right at the beginning, and the F2 on the HM3 was 15 by 90 millimeters. That's a nice big fat F2, which let the stone stay in the energy of the blast path for longer periods of time. I made a list of some of the other units, some of which are still on the market, some of which are not. But as you can see on this list, the size of F2 varies from a fairly large F2 on the Dornier all the way down to this little small F2 on the Direx unit. And I think if you have a smaller F2, you may not get as effective fragmentation because the stone may not remain at F2 as you're treating. When we look at some of the earlier units, we see that we can break it down into volume and peak pressure. Again, the HM3 sort of got it right. It allowed us to have a large volume of energy at F2, a large F2 focus, and we could use lower energy and not get into as much trouble with renal damage as if we might have gone over to the Storch unit, which had a very, very small F2, requiring us, in order to break stones, to use higher peak pressures. And again, that ran the risk of potentially requiring us to do more shock waves and potentially higher energy, potentially causing damage to the kidney. We know that when we did studies back in the 80s, when we first started doing shockwave lithotripsy, and we did CTs afterwards for our study patients, as many as 25% of patients were coming up with renal hematomas after shockwave lithotripsy. And a lot of it was related to this breakdown between peak pressure and F2 size. Improving fragmentation, stones spending more time at F2. General anesthesia, for me, made a big difference. If I could control respirations with general anesthesia as opposed to just IV sedation, and particularly with general anesthesia, we ask our anesthesiologists to use very low tidal volumes with a higher O2 saturation so that we can get very minimal excursion with the diaphragm. Under general anesthesia, we could control that. We could keep the stone for longer periods of time at F2, which meant better fragmentation, fewer number of shocks. Some of the early studies back in 2000s looking at this showed that if we just used sedation, we weren't going to get as successful fragmentation as we got with general anesthesia. Again, this is an early study in the Journal of Urology, and they didn't do a good job in terms of defining the actual stone-free rate. They just talked about success rate, which varied. Here's a second study a year later with a different group. Again, the same point was made. If we're doing this with general anesthesia, controlling respirations, although it was a small study, we see that there's a significant difference in being able to effectively break stones. Slower rates, slower shockwave rates. The original HM3, many of the original electrohydraulic lithotripters, we were synchronizing our shockwave treatment to the QRS complex. The shock wave would fire on the R wave. The idea was that we were going to have less chance of an electrical damage causing a cardiac abnormality. But as we did this over the years and we got newer lithotripters, we found that we didn't really need to gate. And therefore, we were able to ungate. And so the knee-jerk response was, well, geez, if I don't have to go at a rate of 70 or 80, let's push that sucker up and go at a rate of 120 shocks per minute. And so we started doing that, and we found out that didn't work so good because we weren't getting as good fragmentation, and we were getting more postoperative hematomas and hematuria. So what we learned over time was that a slower shockwave rate was much better. Studies have shown that if we can slow down the shockwave rate considerably, we're going to improve our fragmentation, reduce potential injury to the kidney. This was an in vitro study where they looked at fragmentation rates. And as you can see, obviously, if we could somehow go to 30 shocks per minute, we were going to get much better fragmentation than if we went to 120 shocks per minute. I think for most of us that are doing shockwave lithotripsy now, we've sort of compromised and we're going at 60 shocks per minute in general. Hopefully not too much faster than that. When the shock waves hit the stone and we begin to break up and we get fragmentation coming off the stone, it's creating these small fragments around the stone. And one of the things that happens if we're treating in a very rapid fashion is the shock wave comes in and these small particles affect the incoming shock wave, so you're not able to get all the components to break the stone. The cavitation bubbles are disrupted, and the compression wave is thrown off by running into these clusters of stone fragments around it. So again, the emphasis would be on going slower, reducing the number of shocks you need to break a stone, and getting better fragmentation with less renal injury. Looking at our pressure waves, we see that the majority of the energy breaking the stone is at the P plus, and that's really not affected by rate, but the negative pulse wave is affected by rate, and we're going to get more energy, better fragmentation if we can do our procedures at a slower rate. Here's another study again from 2002, pretty much emphasizing if we could go slower, we're going to get better fragmentation. The main concern would be with going slower, are we going to add a lot of extra time to the case? And I think that the majority of the studies show that yes, you do add some extra time, but you're going to do significantly fewer shocks to get better fragmentation. And by doing fewer shocks, you're going to have less potential risk and damage to the kidney. So I think it's a fair trade to add the extra time, the extra anesthesia, to go at a slower rate and get improved fragmentation. Hounsfield units. This is something that we didn't know about and weren't using during the early years of shockwave lithotripsy, but in the later decades of doing it, we realized that if we took a look on the pre-operative CT at the Hounsfield units, it gave us a great advantage in terms of deciding who would be a good candidate and who would be a less candidate because of resistance based on stone composition. Obviously, calcium oxalate monohydrate stones may not break as well as dihydrate, and we found out that cysteine stones didn't break as well in general because of their composition. Stones that have Hounsfield units between 500 and 1,000 are going to break much more effectively than stones with Hounsfield units greater than 1,000. I think most of us can ask our radiologists to calculate Hounsfield units. Many of our patients that we're seeing these days come in with a low dose stone protocol CT from the ER. And I think that if you can generally have your radiologist help you out, giving you pound units, it makes a big difference in deciding whether I should manage this patient's stone with shockwave lithotripsy or move on to ureteroscopy and laser fragmentation. Stenting. There was a period of time in the first decade or so that we were doing this, that we thought if we put a stent in, particularly for stones in the ureter, we create a little membrane of water around the stone and allow the shock wave to work more effectively. But over time, we realized that that really wasn't the case, and there wasn't really no advantage to placing stents for small to moderate-sized stones. I took my children to Disney World a week ago, and as you can hear, I came home with one of Disney World's viruses affecting my ability to breathe and cough. I'm sorry. For stones that are larger than 20 millimeters, I think there is an advantage to placing a stent because it's going to help you clear fragments and may help to reduce ER visits in the future. Stone location plays a role. Obviously, stones in the lower pole will break but may not clear as effectively. Stones in the renal pelvis are going to generally clear more effectively than some of the calyceal locations. So that can be a factor in deciding what you're going to offer your patient for best management. Percutaneous versus shockwave lithotripsy. Larger the stone, better you're going to do with a percutaneous procedure. I think that we're still in the frame of mind that if we're in that 10 to 20 millimeter size, that shockwave lithotripsy is an option. But I think once we get much above 2 centimeters, I think you're going to do much better to offer your patient an alternative procedure like a PCNL, particularly for stones that are located in the lower pole. Inversion therapy. I don't know if this is something that anybody else is doing on a regular basis, but I found in my practice that it does make a difference. It helps to clear stone fragments, and so we used it, and we had tremendous success with it when we were doing very high volume shockwave lithotripsy. We ask our patients to start with an empty stomach, so maybe sometime after dinner in the evening, have 2 8-ounce glasses of water, give 30 minutes to let that get absorbed and increase the fluid inside the kidney. We ask them to place themselves in a slight 30 to 45 degree incline and to have someone sit next to them and maybe use a small hand vibrator to vibrate the kidney, with the idea being that we're going to shake stone fragments out of the lower pole into the renal pelvis. And when the patients stand up, they would actually notice after doing this a number of times that they were clearing fragments after the exercise. And the studies did show that people were more effectively clearing fragments with the combination of inversion therapy and some diuresis over time to get some of these fragments out. And I think it's a worthwhile thing to offer your patients if you're treating a 10 to 20 centimeter to 20 millimeter stone, and you know you're going to have a lot of post-ESWL fragments. Stone location, again, makes a decision about what you're going to do. I don't think there's any advantage for placing a stent in proximal ureteral stones in terms of bypassing the stone or trying to push it back up early on. For the first few years of doing shockwave lithotripsy, I would go into the OR, and if I had an impacted stone in the upper ureter, I would put a catheter up, put contrast in, maybe some lidocaine, try and loosen the stone, push it back into the renal pelvis, thinking that I would get better fragmentation. Subsequent studies showed that probably isn't necessary. These days, if I have a patient who's in pain and I'm talking about putting a stent in for pain control, I'm probably not going to even think about shockwave lithotripsy. I'm just going to take my ureteroscope up and laser the stone, as I assume most of you are doing as well. Well, shockwave lithotripsy, is it still something we should be doing? According to the AUA guidelines, clinicians, it is something that's still standard of care. Clinicians should inform patients that shockwave lithotripsy is the procedure with the least morbidity and lowest complication rate, but ureteroscopy has a greater stone-free rate in a single procedure. So I think there's things that are important to document for your patient that you've discussed that. Shockwave lithotripsy versus ureteroscopy for proximal stones, again, depends on stone size. If we have the smaller, less than 10 millimeter stones, I think we're going to do reasonably well with both techniques. Again, always better with ureteroscopy. If it's greater than a centimeter, I'm much more likely to go up with my flexible scope and laser the stone. This is a different study, also back in 2005 when we had time and money to do this kind of stuff, showing the same thing. Distal ureteral stones. Back in 2005, we were offering shockwave lithotripsy as a less invasive procedure for the smaller stones. I'm not so sure I would be doing much shockwave lithotripsy for distal stones these days. I'm going to take my scope and go in and laser it and be done with it. But anyway, this is what we were thinking about at the time. Certainly for larger stones or more impacted stones, ureteroscopy was a better option. Now, how can we improve safety and reduce tissue damage? Voltage steeping. Studies have shown over the years that lower voltage shock waves cause vasoconstriction of the entire kidney and protects the treated segment of the kidney from hemorrhagic injury. So it's ideal when you start shockwave lithotripsy, even today, turn your kV down, get it way down, and then gradually increase that kV over 300 to 400 initial shocks. That's what I've been doing. That will clamp down those vessels, reduce injury to those vessels, reduce your risk of postoperative bleeding or hematoma. What about aneurysms? Renal, abdominal aortic aneurysms. They're not absolute contraindications, but I think in this day and age, we've got better options. We're probably not going to treat them unless for some reason we're forced to. What we thought about back in the 80s and 90s was, if we're going to treat an aneurysm with shockwave lithotripsy, the diameter for a renal artery aneurysm should be less than 2 centimeters, and for an abdominal aortic aneurysm, less than 5 centimeters. The stone to aneurysm distance, 5 centimeters, as measured on CT, and not on the parallel axis to the shock wave. You're always going to want to use the lowest kV possible. Again, I think probably in this day and age, we're just not going to take that risk. We're going to use an alternative. Cystine stones, they just didn't work with shockwave lithotripsy. Occasionally, if we had what we call a rough cystine versus a smooth cystine, a cystine stone that had a sort of calcified exterior, we might get fragmentation with shockwave lithotripsy. But I think in this day and age, you're likely going to treat with laser fragmentation or a PCNL for a cystine stone if it doesn't respond to medical therapy. Pacemakers are not an absolute contraindication. It's safe to treat with shockwave lithotripsy for single chamber pacemakers if the piezoelectric activity sensing rate response, if it works with a sense rate response, you want to turn that feature off during shockwave lithotripsy. If it's a dual chamber, you want to reprogram your pacemaker to a VV1 mode or ventricular pacing. And I always make it a habit to have cardiology available on call to come to the OR if I need them, with a magnet in the OR with me for anesthesia if we have any issues. If the pacemaker's in the abdomen, I'm generally going to consider other options. Defibrillators, same thing. Usually, if they're implanted in the abdomen or if in proximity to the shockwave blast path, we're going to avoid using shockwave lithotripsy. If the stone is on the contralateral side, you can check the unit post-op after the treatment and have cardiology make sure your defibrillator is still intact and functioning properly. Bleeding diathesis is obviously a contraindication to shockwave lithotripsy in many cases. Again, with the newer technologies, with our lasers, we're going to be less inclined to offer somebody shockwave lithotripsy if they have any type of concern about a bleeding diathesis. Shockwave lithotripsy in children is still an option, depending on where you are. I think that for many of us, though, we're using our smaller scopes and going in and dealing with the children with our endoscopic procedures as opposed to shockwave lithotripsy. Morbid obesity. If you're dealing with a fairly obese patient, you want to know the weight limit of your unit. Generally, they're in the 300 to 400 pound range. You want to know the distance of F1, where the shock wave is generated, to the second focal point. You want to know your skin to stone distance, which you can measure on the CT. I often will bring a patient in, put them on the lithotripter, and simulate them before anesthesia is induced to see if I can get the patient into the second focal point. I'll adjust my membrane down to a minimum level to try and get them as close to F2 as I can. I may actually stand over the patient and push the stone towards F2 using some compression to try and get the stone at F2. And again, then with general anesthesia, trying to hold the stone at F2 as much as possible. Here's a problem that we can run into. Should we shock this patient? I think it depends on where the stone is located. He's 389 pounds. He's sort of at the upper limit of our shockwave table. If we measure the skin to stone distance and it's within reason, we can treat the stone with shockwave lithotripsy. I think we need to think about what stone we're treating. If we're treating a stone in the kidney, the distance is from skin in the back to where the stone is. So this stuff, this pedunculus in the front here, doesn't really play a role. As we move down the ureter, the distance away from the blast path can increase depending on how much fat is in the back. So you need to look at it, you need to think about it. Doing shockwave lithotripsy, it may be a reasonable option in some of these patients. And as we know, flexible ureteroscopy is not always the easiest thing either in these individuals. So to summarize the things that we've learned over time, shockwave lithotripsy is best for small to moderate size stones, preferably not in the lower pole. There's no need for stenting in the majority of stones that are less than 2 centimeters. For smaller lower pole renal calculi less than 10 millimeters, mechanical maneuvers may improve stone-free rates. The inversion therapy technique may help get some of those fragments out if you've decided to do shockwave lithotripsy, or even if you're doing laser lithotripsy and you're leaving some of those fragments behind to clear, the inversion therapy may help. Clearly, voltage steeping is important. Turning down your KV, ramping up slowly is going to reduce injury to the kidney. And obviously, treating at a slower rate will improve your treatment results, as we've shown. and obviously, holding the stone at F2 for a longer period of time with anesthesia and, if possible, lower tidal volumes. In situ shockwave lithotripsy is reasonable first line for non-cystine stones in the ureter that are under 10 millimeters. For complete obstruction greater than 1 week, placing a ureteral stent before shockwave lithotripsy may be necessary, but if I'm going to do that, I'm I'm just going to go to ureteroscopy. If you need to place a stent, consider ureteroscopy. Don't do shockwave lithotripsy in women of childbearing age with mild to distal ureteral stones. I think most of us in that situation are going to probably turn to our flexible ureteroscopes and deal with it with the laser. And as we mentioned, pharmacology may facilitate clearance of fragments after shockwave lithotripsy and the inversion therapy. We are at peak bloom in Washington for our cherry blossoms. I wish you were here and could look out the window and see them. It is absolutely spectacular around the tidal basin. I want to stop here at this point since we're coming up on 10 minutes left for any questions that you have. It's been a delight, and I thank you for your time, and I apologize for my voice.
Well, thank you so much for that talk. Every time I would write down a question, you would answer it in the next slide. So it was all inclusive and very helpful, especially for, like you said, residents that may or may not be doing much shockwave. You brought up the percussion inversion therapy, but do you ever use diuresis with that? Because I have read some articles about either giving Lasix or even like drinking a beer before they do the inversion and percussion therapy. And then I've also seen where they use the chest percussion devices that they use for like cystic fibrosis, where you put the vest on to try and clear fragments as well. Do you have any experience with that?
We did recommend a diuresis. Mostly what we were trying, though, was just, start on an empty stomach, have 2 big glasses, 10 ounces of water, give it a chance to get into your kidney, and then just a little small hand vibrator, one of those little things you can buy at the drugstore. If somebody just sits by you and vibrates, it really did shake it loose. I hadn't tried any kind of a chest compression thing. But when we first published this, we looked at a fairly large number of patients, and the difference between the people that did it and didn't do it in terms of clearing fragments seemed to make a difference to make it worthwhile to encourage.
Yeah, I think it makes a big difference. And actually, I've used it not only in shockwave patients, but also patients that are immobilized that tend to form the sand in the lower part of their kidney. That you can get a family member or an aide to just do what you were talking about. It makes a huge difference in the clearance of that sand.
I find a lot of my younger colleagues now who have been doing this for a while, everybody's sticking up access sheaths, which I was always reluctant to do unless I had the patient pre-stented, but they're putting in access sheaths, and once they go up and laser the stones, they're basketing and pulling the stuff out. Whereas when I was doing more of this a number of years ago, I wasn't using the access sheaths as frequently, and I would just go up and really try and dust the stone and then use the inversion technique to try and clear the fragments over time.
Yeah, I think that is a technique that not very many people know about, but is highly helpful. And then I just wanted to touch on a couple of other things. You had said, don't treat distal stones in women of childbearing years, but just for the residents, I still occasionally, once every few years, see a woman who's pregnant who got treated with shockwave. Can you just comment on whether you would ever treat a pregnant woman with shockwave and why or why not?
I probably wouldn't, because I wouldn't need to. I don't see why. I would not be afraid to go in with my ureteroscope and laser the stone. And I don't know that the data is 100% that we shouldn't ever use shockwave lithotripsy, but I don't see any with the equipment that we have with our lasers now. I don't see there's any reason to take any chance.
Yep.
How do you feel about that?
I agree. I think ureteroscopy has been found to be safe in pregnancy, and I think there's just way too many unknowns with shockwave and the developing fetus. So, and then you had briefly mentioned stents. I know the AUA says no stenting for shockwave, but then the data says you're less likely to have a complication if stents are placed when you shock large stones. So is there ever a time that you'll place a stent with shockwave?
Yeah, I think in my slide, I suggested that the stones are in that 20 millimeter range, the 2 centimeters. I'm likely going to place a stent in those individuals. And so I'll do it during those cases. But again, as I'm getting up into those larger stones, I'm more inclined to just grab my laser and not think about the shockwave as much. And that's part of the reason why I was having this talk, because I'm afraid a lot of our residents are going out and they haven't done enough shock waves to think about all these little nuances. So I just wanted to, I'm glad we have this documented and people can look at it if they find themselves in a situation where it is part of their practice.
Okay. And just looking at some of the comments in the chat. So, obviously you can't get an HM3 anymore. So if someone were to go out and is shopping for a shockwave lithotripter, what would you recommend they're looking for, and what's been shown to work?
I've always been partial to electrohydraulic, but I have to admit that I'm starting to see more and more advantages to the electromagnetic units in terms of convenience. You're not changing spark plugs. Many of the newer electromagnetic units, you don't have to do any water. You don't have to put the distilled water in each time or every day. So I think that people need to look at what technology would work best for their institution. I've always been a big proponent of if I can buy a lithotripter for under $500,000, and I really want that in my institution every day, not just every 2 weeks. Because if I'm going to do shockwave lithotripsy, I want to do it when you come in and you need it, not have to put a stent in and send you home with a stent in for a week while you're waiting for me to do shockwave lithotripsy. So I think as the cost of these things have come down, and for many of the newer units, they're modular, so you don't have to have it sitting in an OR every day, all day long. You can put it in a closet. You don't have to buy a C-arm in many cases. You can use your hospital C-arm. I think they're very, very economical and affordable for an institution to invest in that technology if that's something that you would deem valuable to your practice. I mention that because you and I both know flexible scopes don't last forever and they're expensive. And if I'm in a 4-man urology group in a smaller hospital and we're doing a lot of, laser lithotripsy, somebody's got to be buying and replacing those scopes. Well, maybe in that case, having a shockwave technology for some of the more manageable stones that could be treated with shockwave lithotripsy would pay dividends in terms of reducing hospital costs.
Yeah, and I think it's probably shocking to residents when they graduate their programs. Academic programs notoriously do very little shockwave, right? And then they go and join a big group and they're doing a lot of shockwave, and it's just blindsides them because they really weren't exposed to it. And then the art of shockwave lithotripsy is being lost because, like you said at the beginning, it's who's doing the case that really matters. The setting it up, making sure there's no air between the head and the patient, targeting the stone appropriately, and then using ramping protocols and keeping your pace down. So I think this is really important talk that we tend not to teach the residents. So
thank you. I mean, I hope so. And again, I that was one of the most important slides is getting it set up properly. Now, I guess if you have your own unit, then it sort of falls on you to train your staff and to be there to do it. Now, I think with a lot of the mobile units, hopefully they're coming in with a technician who knows what they're doing and knows how to look for all those things. But I think, if I'm the physician, I'm sort of captain of the ship. I want to make sure that all those little points are ticked off. And, have we got a good couple? Are we ramping up? Are we keeping the stone at F2 as much as possible? So I think those are all important things for the residents to try and remember if they haven't had a lot of experience when they go out to treat in those situations.
Well, all very good points. So I truly appreciate you taking your time to give us this lecture. It was fantastic. And with the cough, you did awesome. And I really appreciate you hanging in there and getting through that and doing it. It was really helpful for us. And thank you again.
Amy, thank you so very, very much. It's been my pleasure.
All right. You have a wonderful evening.
You guys too. Thank you.
Bye-bye.
Bye-bye.